will be joining as the hour goes forth. This is one of the monthly Mailman Center Grand Round sessions. I'm Dr. Larry Friedman from the Division of Adolescent Medicine, and we're also going to have some comments from Dr. Ofelia Alvarez from Hematology and Dr. Jayanthi Chandar from Nephrology. This is part of the Mailman Center's reorganization, and there are different interprofessional collaboratives, IPCs, that have taken turns presenting as this Mailman Center process of change is underway over the last almost 2 years. And the Lifespan IPC was formulated to kind of bring together the clinical perspectives and challenges that we have with children as they're growing and then getting out of the pediatric age group more towards young adulthood and into the internal medicine age group. And we decided to present on our challenges with transitioning children with chronic diseases, because with the medical center setup that we have, we all share these challenges. Why we chose this topic is because the Department of Health and Human Services almost 15 or about 15 years ago reviewed chronic disease statistics in the United States and realized that 13% of children have special health care needs, and greater than 90% of them from childhood actually make it to the adult age group. And they were seen to be less likely to finish high school, to pursue other education, find a job, live independently. But the Department of HHS realized in 2001 that this is not a new problem, and as far back as more than 2 decades ago, there was already a concern in the federal bodies that we weren't doing a good job in the United States with healthcare transition from child to adult settings. And it was important to realize at the time that healthcare transition is purposeful, it's planned, it's not merely a transfer, but it's a process whereby adolescents and young adults with chronic health conditions and disabilities could be moved from a child-centered to a more adult-centered process. And these are not necessarily the exhaustive list of references, but you can see back in 1995, there was already publication in the Journal of Adolescent Healthcare, position papers from the Society for Adolescent Medicine, the American Academy of Pediatrics and Family Practitioners and College of Physicians all had a consensus statement. And then mostly in the literature, what you find are really specific examples of certain kinds of patients that are transitioned, like those with special health care needs or those with cystic fibrosis. But there isn't much globally about commonalities that we face in child care as kids with chronic diseases and disabilities and intellectual challenges are moving to the adult world. The age range of adolescence and young adulthood is actually kind of variable depending on which organized medical body we see, but in general it's the second decade of life between childhood and adulthood that constitutes the age group that we then find challenging for transferring care into an adult system. So just to remind everybody, because I can't help it, being from the Division of Adolescent Medicine, that teenagers are not children, but they're not adults either, and a lot of them share characteristics. And in a healthcare setting where we see chronic disease, we know that there are delays in growth, delays in puberty, social delays because it may be long-time absences in school. Chronic diseases sometimes affect IQ, and intelligence can be compromised depending on the process and even the treatments. We also, just to review, can see now with reminders of the different milestones that teenagers have to negotiate as they grow up, where some of the fall off can occur as people are growing and going through puberty and establishing personalities and not really being able to understand long-term consequences of life and behaviors and having a future orientation till well into late adolescence and young adulthood. We know that there are brain changes, especially in executive function and decision making, that last well into the 20s. So oftentimes the adult care providers are still dealing with young patients of theirs who are still having these developmental processes. Now, our state, Florida, almost 2 decades ago at the University of South Florida, recognized that at least with kids with disabilities, special health care needs, there was a problem with transition, and they formulated this What's Health Got to Do with Transition program, which morphed into Children's Medical Services of the Department of Health having a project called Florida HATS, which was for health and transition services. The website has toolkits, information, different checklists and resources and recommendations for how to accomplish this. So our state actually was a little bit more proactive than a lot of others in helping to formulate services. One of the things that this project of the Children's Medical Services did was interview people, patients, clinicians, ancillary health personnel, and it became apparent that there was a disconnect between what people's definitions are in moving from child-centered care to adult care. And transfer and transition are not equivalent terms. Transfer implies just that there's, okay, here's your referral, make an appointment, good luck to you, and as you go to become an adult now, your care will be at that adult center. That's entirely different than transition, where there's some assistance in helping the young person and their family make that or have that ability to make it to the adult setting and be successful in it. It doesn't happen automatically. It requires planning. These are some of the conclusions that the Children's Medical Services, the Florida HATS project, and then national care or stakeholders have elicited. Young adults with disabilities and special health care needs do require ongoing medical attention, but sometimes expertise in the adult setting is lacking. And now we have insurance concerns and coverage and who's going to pay for services, let alone the social and legal aspects of young people becoming adults and maybe not having the ability to be independent or have the capacity to care for themselves. And all of this requires time, and certainly in medical settings, it can't just be the doctor, the nurse, but we have to utilize our interdisciplinary colleagues in a lot of ways. There have been some suggestions and models that creating clinics specifically for teenagers and young adults would be helpful in emphasizing that this is a transitional point of life. There have been models where adult doctors come to the teen or pediatric clinics to meet youth before the actual relocation to the adult service. There's a model of establishing med-peds care so that that's a natural transition. That tends to be more for primary care rather than the specific specialty needs. And then there are models of co-located clinics where adults and children are seen at the same center, maybe in different hallways or in different floors, but at the same location so that at least that's consistent from childhood to adulthood. There have been suggestions about the importance of the pediatric provider giving recommendations to possible adult caretakers, providing the information to the adult caretaker so that the teenagers and their families don't have to necessarily know the entire medical history, having peer advocates and mentors, teaching youth about their health care and about what's important. Of course, that's reliant on the fact that the youth has normal IQ and the capacity of maturity to do that, which some of the kids with chronic diseases, and definitely the ones with developmental disabilities and intellectual disabilities don't necessarily have. And then utilizing support groups and providing education for the adult providers in what to expect in the chronically ill youth that will be coming to their practice. And a lot of times, a lot of the programs and suggestions utilize nurses and social workers and other support personnel in overseeing the transition. In practice, we realized in our state and across the country that there hadn't been much preparation prior of youth to the whole transition process. But we in our pediatric practices can be helpful in helping teenagers improve their communication skills, you know, not to nod or grunt for the answer or say yes or no, but to expound on their needs and to answer questions more fully. Having teenagers be able to know what their problem is, be able to describe it, have definitions or the real words to describe what their medical condition or their developmental need is. Having teenagers already be independent in their adherence to treatments and medications. Easier said than done, we all know. As teenagers become adults at age 18, there are certain legal changes that take place, but minors for certain health conditions and attention are able to actually consent and have confidential health care on their own. And so pediatric and adult providers have to know those particular conditions. And then there's always going to be change in health insurance and coverage, as well as community resources, which oftentimes patients and their families and even caretakers don't necessarily understand. Other barriers that were discovered in this qualitative interviewing process that pediatricians often termed parents as being a little emotional, overly protective, and sometimes having unrealistic expectations about what the adult setting will be. You have to realize that our patients that we see in a pediatric setting have all kinds of extra attention to their development, and we have funding for different personnel that are not common in the adult world to have all the assistance that children get. Pediatricians identified some systemic barriers. We know that Medicaid, for instance, cuts off when teenagers turn 19, and there have to be independent applications then that a lot of youth don't know how to do and their parents cannot do for them any longer. Sometimes in the adult world, there's specialty care for the specialty problem, but not necessarily adult providers who are comfortable with primary care of young adults now who are transitioning, who have developmental problems, other kinds of intellectual disabilities, etc. And adults practices don't usually have case management. And teenagers and children frequently have transportation assistance with bus cards or the ability to get a Metro Pass that are transportation services for their disability, which a lot of times are cut off at adulthood. When interviewing adult providers, the process found out that adult clinicians felt constrained by some of their medical care guidelines from the managed care systems, maybe low reimbursement rates for office visits, the time required, etc., as you can see. But a big one was this lack of information about existing community resources, which pediatric providers a lot of times know, families know, but a lot of times the adult caregivers and their office staff do not necessarily know. Adult providers have to get accustomed to the transitioning patients with developmental disabilities and chronic diseases, but they've had limited training and experience perhaps in their own residency programs or post-residency CME courses. And once an adult doctor is found to be by a family very acceptable and maybe has expertise that even the patient touts, oftentimes there's this word of mouth transition that allows or that could produce an overwhelming number of medically complex patients all wanting to access the same clinician. These were some of the limitations of adult providers that were elicited in the Florida HATS survey. Youth and families were also interviewed. Some felt not very well informed or prepared about what to expect in the adult setting. They're accustomed to all of this nurturing care, developmental orientation at the pediatric setting, a lot of social support, a lot of financial services, which don't necessarily transfer and oftentimes do not transfer into the adult care model. They felt confused, youth and families. Sometimes the youth themselves were not taking responsibility for managing their own care. Oftentimes parents are reluctant to give up that responsibility. Parents sometimes still want to do things for their youth and after age 18, and youth still a lot of times want their parents to do things for them, but legally they cannot unless given permission or established in a court of law guardianship. So there are those kinds of aspects that come up in adult settings because adult offices don't give information to anybody about the care of their patients who are adults, because that is the patient, the adult. And then our own experience, just to move the process along, is from our care of teenagers who have acquired HIV, allowed us to develop a process that we thought was helpful for the patients that we see here in the special adolescent clinic. So on average, we have about 90 patients enrolled per year. There are always ones coming into care and then graduating out of care to the adult service. The perinatal cases mostly are seen by pediatric infectious diseases, and their experience with this transition process was really quite different for those cases that had perinatal HIV acquisition than we saw with the teenagers who acquired HIV. And I don't see Anna Garcia. She was going to try to come to, maybe during the discussion, talk about some of the challenges that they were having or that they continue to have with their patients. We have a multidisciplinary and multicultural staff, which has been helpful. That includes nurse practitioners, nurses, social workers, case managers, psychologists, etc. I highlight the peer educator because I'll say something about that in a second. And don't neglect the importance of a community advisory board, because parents whose children have experienced these needs have great experience and tips to help all of us in what would hopefully be a successful transition of care. In our own special adolescent clinic, we have a life skills education course that case managers, social workers, the peer advocate, and then the medical personnel all take turns teaching to youth who have to negotiate, and more than just these topics that are here, but all the peer pressures and all the educational goals that are important have to be sort of reiterated, taught, mentored, role modeled for youth. And then I know that's kind of hard to see, but we've had a couple of publications about our own transition care model in the teenagers and young adults with HIV who have acquired HIV, such that we discuss right early on, as after we meet the patient and enroll for care, the fact that they won't be with us forever. Our transition age is actually at 25, not because we wanted to care for all these people into their 20s, but we got involved with HIV research that the NIH was doing, And at first it was through age 18 and up to 21 then, but when teenagers were enrolling into research protocols, and we were successful in retaining them in research protocols, the NIH didn't want us to just stop at age 21, and they didn't want those patients to suddenly have to pick up with an adult care group trying to maintain the long-term follow-up of whatever was being researched. And so they sort of begged us to keep the kids up to age 24. Also, the pediatric ID group was encouraged to keep their patients up to 24, to just have that extra couple of years of research data, recognizing that everybody does across the world, that people in that early 20s, kind of, older teenage and young 20s age group, behaviorally are much more like teenagers than they are like 28 and 30 and 32-year-olds. So there was some sense in keeping the young 20s with the pediatric age group. So at the young 20s age group, we have an adult infectious diseases HIV expert actually present in our special adolescent clinic. And she comes monthly, Dr. Alexis Powell, and she meets the transitioning youth in the familiar adolescent setting here at the Mailman Center. And then she continues to see that transitioning youth for the routine health care, the specialty HIV care, for the whole, at least a whole year. And at age 25, then, with the social worker or the case manager or the peer from the adolescent group, Dr. Powell sees the young adults now over at the adult clinic, but with the familiar buddy, the case manager or the peer, kind of helping the process along. And then after that successful first appointment as phase 4, the phase 5 is continued care in the adult setting. We haven't been as good about the follow-up to know about successes, because that always requires funding, and that always requires IRB kind of work, and that always requires a consent, because when you give up the care of your patient and they enter a relationship with a new clinical setting, we no longer have rights to just know everything about that patient. They've engaged in a new doctor-patient relationship somewhere else. So we have to get consent from the young adults to even access some of that information. And what we perceived to be successful was actually patient maturity, the ability of the patients to act independently, and those that had a strong support system outside of the clinic. And that isn't necessarily the case for a lot of youth with HIV who have acquired during adolescence, because their adolescence was chaotic, something about their education was lacking, something about their ability to feel vulnerable or take prevention precautions interfered with a lot of it. So we don't necessarily have a lot of mature, independent patients with good outside social support to have a successful transition. And then we also try to know who the adult providers are around town to kind of match patients to settings or to clinics that we think might be more successful. Sometimes it has to do with location, sometimes it has to do with who the youth thinks they might see at the new setting. A lot of times teenagers with HIV don't want to go to a place in their own neighborhood where they think that other people they'll know and will see them, and then their diagnosis will be disclosed. Sexual orientation for our patients with HIV also is something that we take into consideration, which other medical problems don't necessarily need. And then we found it to be to have a single contact person at the adult settings was much easier to make this transfer of care and to provide information for this transitional kind of process. And then, of course, with children and teenagers in pediatric settings, we always have to be flexible because something comes up, some rule is changed, some behavior interrupts and interferes, and we have to go with the flow. So we learned that there's a need for ongoing evaluation still, that esteem and confidence issues still remain as problematic or helpful, depending on how high the esteem and how high the confidence are in this transition, that adolescents still have knowledge gaps, and for appointment adherence and for medication adherence, it's really the clinic setting in the adult world that matters a lot. And then we always have to keep in mind the insurance, financial concerns, etc. We were involved in a HRSA project for transitioning HIV positive youth from adolescent to adult services, and they put out a toolkit that has a table of contents and all kinds of lesson plans. But they advocate really nationally from experience having youth mentors, at least in the HIV world, to help with the transition. And part of the toolkit actually teaches teenagers and supports young adult youth who are HIV infected to become mentors and buddies and role models for other youth. And just our take-home tips were these: to have a structured plan in place and discuss transition early, offer different options, and work with the appropriate adult providers who are interested in the care, have expertise in the care, and are welcoming of the population that we're trying to transition, and of course maintain flexibility. Now we're going to switch to another experience at our own Department of Pediatrics with Dr. Ofelia Alvarez talking about some of the challenges in sickle cell, and then we'll have Dr. Jayanthi Chandar from Nephrology talking about some of the challenges that they face in that particular entity. And then we'll have time for discussion and commentary.
Good morning. So our idea about creating a transition program was to improve outcome for our patients. And just to say that the survival of patients with sickle cell disease in the United States is still around the 40s, 40 years of age, 42, 48 years of age is the median age, which is certainly much better than before. But when we look at the mortality by age groups, we still see that in the pediatric age group, we are doing very well. But there is certainly an increase in mortality, a triplication in the mortality in the young age groups, 20 to 24. There's certainly an increase there, you see in the curve. And the median age for survival, for mortality is between 35 to 44 years of age. And these have not changed very much. But certainly we have to do better in the young adulthood. And there is a lot of challenges that adults with sickle cell faces. And there are changes in relationship, a lot of stresses in the young adulthood with marriage or new relationships, new jobs, college. The access to care is certainly a problem. Insurance is a real problem, and we are seeing that on the day-to-day basis. Employment and new physicians that they're going to be meeting. And so the transition is a very important thing that we do, and Larry have already defined what is a transition, which is a purposeful, planned, timely transition from a child and a family-centered health care to a patient, adult-oriented health care. And the goal is actually to optimize health and to facilitate that each person attains the maximum potential. And to emphasize, this is a process. It's not only a transfer of care. There are factors that affect transition, and there are some positive influence and some negative influence that I present here. Parental support is a positive. Education, self-efficacy, and maturity are certainly very good influences. But there are negative or barriers. Dr. Larry Friedman already presented that. With us, some negative experiences in the emergency room, cognitive deficits, patients who have a stroke or have silent infarcts, in our group is a real problem. Not finding a doctor interested in taking care of the patients. Thankfully, we have Dr. Tom Harrington, who's here in the audience, and he's an excellent physician. So we are very well in that sense. Insurance changes is a big barrier. Looking at the adults with sickle cell disease ages 18 to 30 years, these are two things that have been published. There is a high medical utilization of emergency departments and hospitalizations. More than twice per year is the mean. And there is certainly a high number of admissions and reutilization of acute care and readmissions within 14 days. Actually, we have a patient right now who has been admitted 3 times in a row, and he did not do that. He's 18 now. And this is much higher than what we see with younger and older patients. And this is a period of increased mortality. In the Dallas cohort, they saw that 6 out of 7 deaths occur within 2 years from transitioning to adult care. So this is a great concern, and that's why we want to do a very strong transition program. The steps that are successful for transition and have been described by the American College of Physicians Transition Clinical Report Authorizing Group are the following. We have to discuss a transition policy with youth and parents and define responsibilities for each stakeholder. We have to begin discussion of the transition plan, utilizing readiness tools, and assess several things, including education, vocation, independent living, self-advocacy, the awareness of medical needs, and age-appropriate preventive care. The practitioners should review the response to transition and assess readiness, and really construct a specific transition plan and complete transition with direct communication between the pediatric and the adult provider, and a portable medical summary, which I have here. We have a little booklet that we prepared. Our transition program is structured among 10 modules. We begin with an independent parent and patient program introduction. We have a transition readiness assessment, which is as the guttransition.org suggests. We have 3 presentations about health and sickle cell disease education. As this is a multidisciplinary team, we have the child life specialist also talking about vocation and college guidance. The genetic physician, the counselor go in another module and meet the patient and provide information about genetic counseling. Our social worker is a very dedicated social worker to this project, and so she's constantly looking into insurance issues, but there is a module especially for her. Our psychologist, Winston Thompson, also is key, and she screens for depression and anxiety, which is very prevalent in our patient population. It is very important how to navigate the system. We actually have a video with patients who have been successful, and it's very important, as Larry mentioned, to have some peer information for them. And then at the end, we reassess the readiness for assessment for transition, and we provide a transition plan and portable medical record. But also, we want to follow the patients afterwards. You know, we have the advantage that in our program is a combined program, and we have weekly meetings with Dr. Harrington. So these are our advantage for us. to see what's happening, because again, the transition is not only to prepare them, but actually to find out what's going on, because that is key for a successful transition, in my opinion. We are a young transition program. We started in October of 2012, and 75 patients are eligible, 42 males and 33 females. We begin the transition process at 16, but our plan is to begin now at 12. And 58 of them, 77%, have started in the process. 24 have completed the transition to the adult provider. And we are honored to be one in 24 programs that were nominated for exemplary care and coordinate the services for children with heritable disorders, one of two with sickle cell disease. So we're really proud of that. This is some information about our program. This is a survey that we distribute in the visit 1. There are 43 patients have completed this survey. And if you see here, 30 to 40% are very nervous and worried about the transition process. And the first lines here. And, but they may be happy, somewhat happy and ready in their opinion. 20% are not happy at all, but the majority is not angry and do not feel abandoned. So we have, I think, good rapport with them, but the thing is to basically start the process. So this is basically baseline information that is important to us. As I mentioned, we use a transition readiness assessment tool. This is from gottransition.org, and these are the questions that need to be completed by the adolescent in terms of things that they know, things that they need to learn, things that they want somebody else to learn, maybe the parent. And so some of them is, I can explain my medical needs to others, I know my symptoms, so they have to be involved and they need to know what's going on with their health. And some planning, such as before I visit, I think about questions to ask, or I have a way to get to my doctor's office. So these are practical things that they need to be knowing, which are going to be good skills when they transition to adult care. I have looked into 25 of the respondents and what has been their main concern and the main things that they need to learn. And 11 of the 25 says that having a copy of the current plan of care is very important to them. 9 say know how to get referrals to other providers. This is key because we have a lot of problems with insurance. And even for adults that are older, this is a challenge. And that's something that we need to teach them how to do, because it's something practical that may be successful if they have this skill. Know what to say to the doctor. 8 of them said that. Plan to keep healthcare. 7 of them. So you can read them here. These are very simple, very practical things. No doctor's phone number. So this gives me the opportunity when I'm assessing them to actually give the information to them. And then this is something that I would be reassessing at the end to make sure that everything has been, the information has been delivered and they have skills and knowledge. Surprisingly, 6 of them says they have nothing to learn. So practice, practice, practice. The patient should meet alone with a doctor without the parent. They need to learn how to make his or her own appointments, to know about health insurance, and how to get approvals for visits, to know what is important for health when they have to access care, to know what medication he or she is taking and follow instructions. Adherence is so important, and to speak and advocate for self in an efficient way. I have looked into transition outcomes, and as I mentioned, there were 24 that were transitioned. We have 21 in active follow-up. Unfortunately, 3 of them are not following up or lost to follow-up, and some of these are issues with insurance. I have called them, and that's have been one of the problems. 15 of these 21 are good follow-up, they're constantly following up. The other 4 is fair, so sometimes they miss appointments. Unfortunately, 2 of them have died. And the causes of death, one was a 21-year-old with liver failure, and it was expected that her survival was not going to be very good. She died outside of a facility. And we have a recent death of a 23-year-old female died during a vaso-occlusive crisis at Jackson. So she has an autopsy, and we're looking at exactly what happened. There is a lot of room for improvement. We need a transition coordinator. We're going to get one hopefully in the next month. We need to be more vocal and give more information about insurance coordination and case management, and to have more shared time between the pediatric and the adult provider. And we're planning to do that. I actually moving my clinic day so we can work together, Dr. Harrington and I and the nurse practitioners, so that will facilitate to have more encounters together with the patients. And lastly, to assess and to provide information to the medical team, meaning internal medicine and emergency room physicians in the adult side, primary care physician, hospitalists and nurses. This is always something very important, that we will educate them about sickle cell disease. I want to mention there are two meetings that are going to be happening, one in July and transitioning of medical home work group here in Florida, and the other one is in Texas in October, so that anybody who's interested, this is a good opportunity. Thank you. I take care of children with kidney disease and children who will be having transplants or have already had transplants. So we have a unique problem with them when they transition. So as in many of the other chronic diseases, children with chronic kidney disease and kidney transplant recipients have health issues that they have to deal with throughout their life. And medication adherence and monitoring their health status is key to their well-being and is important for transitioning from pediatric to adult healthcare providers. So when you look at this graph, these are the graph survivals according to age groups. So the peak time that there is graft loss is between the ages of 15 to 25. So you see the peak over here. So so if you look at the adjusted graft survival, the 10-year adjusted graft survival of kidney transplants, those over the age of 55 and adolescents between the age of 12 and 17 have the worst graft survival. And it's believed that it's because of the issue of non-adherence to medications and the problem of transition of care that contributes to the poor graft survival in adolescents. So barriers to adherence are also barriers to transition. So like Ofelia and Larry mentioned, there are multiple areas where there are problems. So at the patient level, having knowledge of the disease, having functional health literacy, and several other factors that are emotional, cognitive, and so on. And then at the provider level, the ability of the provider to communicate with the patient, educate the patient, and for the provider to be accessible to the patient these are problem areas that need to be addressed. And of course, problems with insurability, like they all already mentioned. So, when I transition a patient, I ask several questions, just like Ofelia said. So this was actually adapted from the University of North Carolina Healthcare Transition Coalition. So these are several questions. First of all, the patient needs to understand his condition or her condition and describe it to others. and needs to know what medications they are on and what they are for, and can the patient make decisions for himself or herself and about his or her treatment. And of course all the other things like the adult clinic arrangements. The patient needs to know to make appointments, make his transportation arrangements, and know all the details about health insurance. Even I don't know all the details of my health insurance, so it's pretty challenging. But needless to say, these are patients who have been dealing with a chronic health condition all their lives. And this is something we need to educate them about, and they need to know who to call in a medical emergency, and they need to be able to talk about their blood tests and other treatments and their concerns, and follow certain dietary advice, and have appropriate knowledge about their sexual health matters, and have to have discussions about alcohol, smoking, and other drug issues. So the culture of pediatric healthcare, we generally tend to be multidisciplinary. We are very friendly people. We're very kind. We do have a lot of emphasis on psychosocial support, developmental issues. We like to be family focused. We are warm, optimistic, flexible. We are informal and relaxed, and we like to develop a partnership with the parent. But in general, the culture of adult healthcare is just very few psychosocial supports. It's always, I wouldn't say always, but in general, it's business-like, formal. It's patient-centered. There's a strong focus on the disease process. If I sent them to the adult healthcare provider, in fact, I have the adult kidney transplant physician practicing right next to me in the clinic. So I tell her, here, this is my patient. He or she is 21 years old, and you're going to take care of this patient, next time. And then she comes, she's very nice, she comes and says hello, and of course my patient is cowering away and saying, oh no, I don't want to leave you, I don't want to go there. And then they see her and they say, okay, maybe it's not so bad, so I'll proceed. But a lot of the times there's strong focus on the disease process. So here I am treating otitis media and pneumonia, and the adult healthcare provider, has the PCP take primary responsibility for all that. So the kidney is a separate organ from everything else, when they go to the adult healthcare provider. So there's insistence on compliance. So there's no room for error. A lot of adult care is procedure and lab-based or lab-oriented, and it requires the patient to be autonomous and to function independently. So, first of all, going back to the very basic issue of literacy. Literacy there is a literacy scale in adults, which is classified as below basic to being proficient, and the score ranges between 200 to 500. 200 being below basic health, 200 and below being below basic health literacy, and proficient being close to 500. So now we require our patients to be functionally health literate. So what is the definition of functional health literacy? It's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services to make appropriate health decisions. So management of a child with chronic kidney disease becomes very difficult if caregivers and children do not understand the information given to them. So 14% of the adult population, 19% of high school graduates cannot read, and that's unbelievable, but that's a fact. 21% of adults read at the 5th grade level, and lower health literacy is associated with less education, obviously. I am so sorry, I don't know why these got erased, but health literacy more or less follows the same pattern as literacy in adults. So about 12 to 15% of adults don't have even basic health literacy skills, and only about 10 to 12% of adults actually have proficient skills. So why is it important? I am sorry. Children with chronic kidney disease tend to have problems with cognition, and if you look at the mean cognitive scores by level of renal function, and you look at it from three angles, IQ, memory, and attention, the lower the GFR, the greater are their deficits in IQ, memory, and attention. So if you look at the yellow bars, they're the ones with end-stage kidney disease. So obviously, a child who has had end-stage kidney disease, say from the first year of life, is going to have the greatest cognitive deficits, and we're expecting these children, to have functional health literacy by the time they turn 18 or 21, and move on and take care of themselves. So what are we going to do about that? So the optimal treatment of advanced chronic kidney failure is kidney transplantation. It does offer better quality of life, but strict adherence to the medical regimen is imperative. If they don't take their medications or miss their medication, they're going to lose their transplant. So then we're back to square one. They're back on dialysis. And once they lose their transplant, they become sensitized. So getting a second kidney transplant is really, really very difficult because they're so highly sensitized and they can't find a donor. So literacy is important to achieve functional health literacy in the adolescent years. And functional health literacy is important to achieve transition to the adult world. So I decided that, we've got to start somewhere, maybe start when they're still on dialysis and then go on to, when they get their transplant. So we have a pediatric dialysis literacy project, and the objective of that is to promote literacy in children with chronic kidney disease through education, advocacy, research, and service. So if you look at the education status of children on hemodialysis in our dialysis unit, so if you take the 6 to 12 year age group, about 75% go to regular school and 25% go to special ed. And when you take the 13 to 18 year age group, about 60% go to regular school, 10% go to special ed, and 30% are below grade level. And when you take the 19 to 21 year age group, I'm actually kind of proud but a little disappointed that 55% actually finished high school. About 10 years ago, the national high school graduation rate was about 60 to 65%. So the most current statistics say that 83% of children actually finish high school. So we could do better than that. And then 27% are school dropouts. So this is pretty distressing, and we expect these children to get transplanted, be adherent to their medications, know all the things that I talked about in the beginning, and then go on into adult life and be productive citizens. So when we looked at the mother's level of education, and our fellow Rosa Sanchez collected these data, only about 38% of mothers were high school graduates. We couldn't poll the fathers because most of the time they weren't there or didn't exist, weren't part of the family, that's what I mean. 34% of mothers were not high school graduates, about 10% were college graduates, and the status is not known in 19%. So we have this program. It's called the Child and Adolescent Motivation and Enrichment Program, in short, CHAMP. And we have a wonderful medical student. Her name is Ashira Klein, and she has a group of medical students who come and volunteer for about 1 hour a week. We are very grateful to the Florida Alliance for Assistive Services and Technology, because they have provided us iPads so that the medical students can go through various programs within the iPad. And it's an amazing program because the iPad has different levels of educational tools, starting from elementary to even high school. So the children love it very much. They enjoy the time they have with the volunteers, and you have to, I have to say there are three types of parents that take care of these children. The parent that is overprotective and overindulgent, and the parent that leaves the child there and says, bye, I'm not coming here anymore. You come with transportation or a caretaker, and I'm not seeing any of you anymore. And that's sad because then a lot of the responsibility then rests with the child to, and the adolescent to take care of himself or herself. And of course, the balanced parent, which is pretty rare among us. So we are trying to incorporate various learning methods. We're trying to see if we can help them with artwork, poetry, storytelling, and then using the iPads and computers for improving core curriculum. And now we have a program where we're going to have the children do both homebound and regular school so that they don't miss out on their education. And each individual will have a folder depicting their own learning plan. And of course it needs a team approach. Like Larry said, we need a psychologist to determine the developmental level of the child and provide appropriate teaching methods, a child life specialist to teach through play therapy, because it's definitely boring to do math and reading if you don't make it interesting, and parent to provide insight into each child, and the social worker to provide us input on psychosocial and economic circumstances, volunteers to help teach and play, and peer to provide guidance and support. So we actually have a transplant recipient who is 19. She wants to be a nurse, so she's in nursing school, and she comes and volunteers and has one or two of the patients that she teaches and plays with. So she really loves the experience. So more often there is mismatched communication, like you can see here. The provider gives information, and the patient has a responsibility of trying to understand, remember, and act on the information. So one of the processes that we're trying to implement is teach back. Here, this was brought out by the Health Literacy Universal Precautions Kit, and basically what it is the clinician explains either a new concept or the treatment plan to the patient. But in order to know if the patient truly understood, the patient is, the clinician clarifies and tailors the explanation by having the patient actually tell the physician what is it that he or she learned from what the physician told him or her. So I'm so sorry that this happened, but anyway, we decided to do a modification of this teach-back method. So we devised a questionnaire, and it's very simple. When the patient comes into clinic, we have them fill it out. So for children for adolescents from the age of 15 and up, we have the adolescent fill out this questionnaire. We have some children under the age of 15 also fill the questionnaire, and the parent too. So here we have them fill out their the date of transplant, their problems, hospitalizations or surgeries since their last visit, their allergies, all their medications, and any questions they have for the healthcare provider. We collected a few of these and analyzed it. I want to say there was one patient who had renal cell carcinoma at the age of 10, so we needed to have a 5-year tumor-free period. So at 15 he was eligible, but he was non-compliant, so we didn't want to transplant him. And at the age of 18 he finally got transplanted. So the first time I posted this questionnaire, this child could not fill it out. He said, don't expect me to do this today. I can't. Because he really did have very poor literacy skills. So then he decided in his mind, he's going to learn, so that every time they walk into clinic, I give them the questionnaires. So he waited a second time and a third time. The fourth time, he managed to put it all on his smartphone, so he copied it from that. And now, 3 years after transplant, he does it all by himself. He advocates for himself and says, this is now not something, this is not how something is supposed to be done. This is what my doctor told me. So now he's learning to advocate for himself. So this has helped us, in the self-management process. So when we looked at, how they did between time 1 and time 2, caretakers generally did okay. Patients tended to improve with repetition of the questionnaire. So at least it accomplishes some degree of self-management, and it shows that repetition helps to improve their skills on learning about themselves. So going back to the original slide, I'm trying to see if we can at least accomplish the first 3 so that we can move on to all the rest of the requirements in order for them to successfully transition.